Muy buenos días para todos. Good morning. It's a pleasure to be here as a coordinator with Dr. Sornina Antonini to present our next speaker, Maria Craig. We know her. She has been our speaker from the first day. Her lecture today is Diabetes mellitus and Immunotherapy, Preservations of Beta Cells. Maria is a pediatric endocrinologist at the Children's Hospital Westmead and St. George Hospital in Sydney, Australia. Professor of Pediatric Endocrinology, University of New South Wales and University of Sydney. Medical Director of the Australasian Diabetes Data Network and President-elect of the Asia-Pacific Pediatric Endocrine Society, APPES. Her major research focus is childhood diabetes, including etiology, epidemiology, evidence-based care, and prevention. She has authored more than 280 publications and is editor-in-chief of the International Society for Pediatric and Adolescent Diabetes, ISPAD 2022 Clinical Care Guidelines. Welcome, Maria.
Oh, yes, thank you. And good morning, and I must say that I'm very thankful to Maria as well, because she did a great job in the summer school with us and our fellows. Thank you for that as well, Maria.
Well, thank you for inviting me. It's been an absolute pleasure. The Fellows School was amazing, and the standard of presentations from all of the fellows was excellent, it was just a lovely experience. And this meeting's been fabulous. I'm trying to brush up on my Spanish, and I hope that you are okay with my Australian accent. Thank you very much for the opportunity to present. I've just taken over as APA's president, and I am here due to a wonderful relationship between APAS and SLEP. So yeah, thank you for having me. So I'm going to cover, before I go on to that, thank you to Sonia for taking us, myself and Abel yesterday, to the Botero Museum and the Gold Museum. If you do get any time before you leave, this is an amazing city, and I feel like I have some new friends. No conflicts of interest to declare. So I'm going to cover a little bit more than just immunotherapy, because I think it's very important to put immunotherapy in the context of where we're at in the world of pre-diabetes, so stages 1 and 2, biomarkers, and what we can learn from other diseases. So hopefully this will be some new knowledge for you. So I'm going to start with the case. There's only one case. This is a child who has 2 first-degree relatives with type 1 diabetes, a father and a brother, both diagnosed at a young age, and importantly, both male. And the mother also has autoimmune thyroid disease. They were recruited to the ENDIA study, which is a birth cohort study that I'm part of, that started actually about a decade ago. And as part of that study, children are recruited during pregnancy, and then a whole lot of environmental and genetic factors are examined, and then they have autoantibodies every 3 months from age 3 months, and then at 2 it goes to 6 monthly. This young girl got her first autoantibody at age 6 months. So what is the risk of type 1 diabetes? And there are a number of factors in the history that are important. And are there any interventions available to this young girl now she's got 1 autoantibody? So this is the ENDIA study, as I mentioned, and the stages of diabetes. So she is now defined as being stage 1 because she has... well, technically she's only got 1 autoantibody, but she does nevertheless have evidence of autoimmunity, and we know that if you get your first autoantibody at 6 months, then you are very likely to get a subsequent antibody and probably progress to type 1. So this concept of staging first came out in 2015 led by Dick Insel and a lot of other experienced people in the world of autoimmunity and clinical trials. And I think it is a very useful schema, but of course we know that for some people their beta cell function goes up and down over months or many years, even decades. And for some people there's a very slow decline, and then there's probably some environmental trigger like a virus or other stress that causes this rapid decline in beta cells. And then for some people it's much more linear, and a number of factors determine what sort of course you'll have, and I'll go through that shortly. So the current biomarkers that we have are autoantibodies, but there are major challenges in our detection of who is appropriate for intervention. And part of that is because we detect organ-specific markers, but we actually don't sample the organ, i.e. the pancreas, except the DIVID trial, which was the DIVID study, which was 6 adults with type 1 diabetes who had pancreatic biopsies. And that's a really small number when we think about how much type 1 diabetes there is in the world. And the NPOD study, which is basically examining autopsy samples of people with islet autoimmunity or type 1 diabetes. So it's very difficult. The other issue is that there are generally very low quantities of markers, whether we're talking about cells or proteins in blood. There's massive issues with reproducibility, both a technical variability and lab-to-lab variability, and not just T-cell assays, but also autoantibody assays. And then probably most importantly, the heterogeneity of type 1 diabetes. And anyone who's worked in type 1 diabetes for a while will know how every person who presents with type 1 will have different autoantibodies, a different clinical picture. It will depend on age, it will depend on family history. And in the children who are part of birth cohort studies like India, we know that some of them progress rapidly, some of them don't. And this has led to the concept of endotypes, which I'll talk about a bit more shortly, and also the role of how high risk you are in terms of genetics. If you are have a DR3/4 genotype as opposed to only DR3 or only DR4, we know they're the children that tend to get type 1 diabetes at a younger age and have a more aggressive course. So this is also, I guess, just highlighting the complexity of measuring risk and biomarkers. We can look at nucleic acids, whether it's DNA or RNA or microRNAs, proteins, not only the antibodies, which have been around for a long time, but post-translational modification, expression of proteins, insulin, C-peptide, and then non-enzymatic protein linkages, and then all these different metabolites that are also very relevant for predicting risk and therefore predicting who is going to benefit from an intervention. So we've still got a long way to go before we really sort out biomarkers properly. The other thing that's really relevant for particularly young people with diabetes or at risk of diabetes, and whether interventions will benefit some children versus others, is the fact that when you look at the first autoantibody appearance, it's quite variable. So the trigger birth cohort that we were part of in Australia that started about 20 years ago now, about half of the children got insulin as their first autoantibody and close to half got GAD, and then ZNT8 and IA2 tended to come later. We don't know why this is the case, and if we really did understand this, then I think we'd be a lot further towards immunotherapy and other therapies for both primary and secondary prevention. In the Teddy birth cohort, which bigger numbers, and this included Europe and North America, so more of a heterogeneous population. Again, insulin autoantibody was just under 50%, but interestingly, GAD was more common. But there didn't seem to be any risk of progression to type 1 diabetes depending on whether insulin was your first autoantibody or GAD was your first autoantibody. But, and this has been established in other cohorts, if your second antibody, if you got a second antibody, your risk was greater than if you had a single antibody, and I'll show you some Kaplan-Meier curves in a second. But if you got IA2 as your second antibody, your hazard ratio was enormous. It was 16, versus if you got IAA or GAD as your second antibody. Obviously, you wouldn't have had IAA as your first antibody, but if GAD was your first and then you got IAA, or vice versa, your hazard ratio was sort of 5 or 6. So there's certainly something, again, we don't understand why, but if you get an IA2 antibody as your second antibody, you are, the writing's on the wall and you are going to get diabetes. And the other thing that was interesting from Teddy is that the younger you were at your first autoantibody, like my patient who got their first antibody at 6 months, then the time to getting your second autoantibody and the risk of progression to type 1 diabetes was greater. How we use this clinically is very difficult, and how we use this in clinical trials is still not established. So this concept of endotypes of type 1 diabetes actually came from a group in Exeter that looked at a bunch of pancreatic samples of people who had died, so cadaveric samples. And they used this cutoff of if you get diabetes at age less than 7 versus 7 to 13 and greater than 13. And again, for the clinicians in the audience who've looked after many children with type 1, we know often those that present at a younger age have a more progressive disease. In the Finnish Diabetes Register, this is a paper that just came out this year, they looked at a very large number of children and showed that if you got type 1 before the age of 7, you were more likely to have a first-degree relative, more likely to have the DR3, 4, more antibodies at diagnosis, and particularly insulin autoantibodies, whereas if you got diabetes in adolescence, more males, more GAD, longer duration before symptoms, but interestingly and a bit paradoxically, you're more likely to have metabolic decompensation and be in DKA, and that's probably because adolescents likely ignore their symptoms. So this, I know this is nearly a decade old, but the data remain very robust. If you've got no antibody, you've got a very minimal risk of developing type 1 diabetes. If you've got one antibody, you've got about a 15% risk in 10 years. And if you've got 2 antibodies, it's about a 44% risk. But really, by 15 years, it's likely greater than 90%. If you have stage 2 diabetes, so you have dysglycemia as well as autoantibodies, multiple autoantibodies, you've got about a 75% risk of developing diabetes in the next 5 years and 100% risk certainly by 20 years. So this argues very strongly for actually staging individuals with autoantibodies, whether it's, and I'll get into this in a second, whether it's via OGTT, glucose monitoring, or CGM. But you can see that the risk stratification is very different depending on whether you're dysglycemic or not. And then if you have greater than 2 autoantibodies, ultimately you are going to develop diabetes, and it's really dependent on whether you've got dysglycemia as to how quickly that will occur. In this paper, that was a combination of different birth cohorts from Germany and Colorado and Finland. I guess this is just restating what we've already said already. If you seroconverted before 3 years, if you were the DR3, 4 genotype, and if you were a girl, you were more likely to progress, and the number of autoantibodies didn't actually make a difference. 2 versus 3 didn't make a difference in this analysis, but certainly 1 versus more than 1 did. So briefly moving on to genetics, because this is very relevant to prediction. We know that there are more than 70 variants associated with type 1 diabetes based on genome-wide association studies. 50% of that risk is from the HLA region, and overall your risk of type 1 diabetes is conferred by genetics. So 50% of your risk is conferred by genetics. So the other 50% is the environment. And I've spent a lot of time looking at environmental factors, including viruses. The really sort of landmark change in prediction has come from the genetic risk score. And Richard Oram has done some fabulous work. He actually spoke at the ISPAD meeting just before I came here, and has really moved from this. Original study was in the UK Biobank, and it was actually aimed at looking at trying to stratify whether young adults had type 1 or type 2, and looking at this genetic risk score of about 30 genes, the area under the curve the area under the curve, what have I done? Can I go back? The area under the curve of 0.88 with fairly tight confidence intervals in a highly significant p-value indicates that if you have this higher genetic risk score, even though there's a lot of spread, you are much, much more likely to actually be diagnosed with type 1. This was 7 years ago, and Richard's done some fantastic work since then looking at different ethnic groups, younger people, and has now developed a GRS2, which has turned out to be a very robust measure and is now being used in a number of population screening programs, including ours in Australia, which has just commenced. This is just looking at, in our clinic population, we looked at type 1 versus unaffected relatives, and then the background population, and this in the multi-ethnic Australian population, again, this score was quite robust. So in terms of therapy, largely studies to date have recruited either first-degree relatives or recruited on genetic risk, and many of you probably know these data, but I think it is very telling to remember that if you've got the high risk HLA, you've got about a 1 in 20 risk of, or 5% risk of getting type 1 diabetes, which is about the same as if you've got a first-degree relative, which I think is quite interesting. If you've got a high genetic risk score, though, that risk goes up further. And if you've got multiple first-degree relatives, and remember the case I presented does have multiple relatives, your risk goes up further. And then if you've got multiple affected relatives plus a high-risk HLA, you're really, it's 50-50. And then, some other combinations of genetic risk and relatives. If you've got a twin, the risk is quite variable, and I guess that argues for environmental factors, as is the case for an HLA-matched sibling. We also have to remember, though, that 85% of individuals with type 1 who present do not have a family history. And then the other factors that are important are the index case, so your sibling or your parent got diabetes at a young age, your risk is greater. If it's a father, and particularly if the father got diabetes at a young age, which was the case for my patient, then the risk is greater. If the parent's older at the birth of the child, it's really not understood why that's the case. Could possibly be epigenetics, who knows, and then male gender. Okay, so moving on to prevention, and I'm going to talk about immuno and non-immunotherapeutic strategies. These can be classified as primary, secondary, or tertiary, which is obviously after diagnosis. And some of these are direct immune interventions, and other potentially indirect or alternatively not actually modifying the immune system per se, but potentially preventing autoimmunity. So just wanted to highlight, I'm sure many of you are familiar with this, but it's very relevant when you are actually trying to recruit individuals for studies in the type 1 space, particularly in populations where the disease is not that common. But even in countries like Australia, we really struggle to recruit the number of individuals unless we're doing a multinational trial. And so that obviously is very resource intensive, as well as all the regulatory side of things. So obviously preclinical studies are not in humans, but we know for many, many hundreds of interventions that have been done in the NOD mouse or other animal models that they turn out not to be successful in humans, but ultimately that is often the way these studies work. Then phase 0 is often just making sure you're not going to kill someone with your intervention. And then phase 1, typically 20 to 100, mostly looking at safety but not efficacy, then phase 2 trials tend to need hundreds of patients, phase 3 thousands. And so if you're doing a phase 3 trial in the type 1 prevention or beta cell preservation space, you really have to go internationally. And then obviously post-marketing and translational research to help to evaluate whether those individual studies were actually effective. And unfortunately, so many trials in type 1 to date have been just phase 2, and then there hasn't been replication of those interventions. And so that's a real issue with regard to then getting medications registered. I quite like this figure from Gerald Nepom and Mario Ehlers, who have worked in this space for a very long time. I think it's a nice sort of, albeit relatively simplistic diagram that highlights, you know, the things to target that where you're wanting to reduce autoimmunity, things that to target to, you know, obviously you can't really target genetics, but targeting the environment and trying to maintain homeostasis, and then blocking all these co-stimulatory molecules and effectors, and, you know, signalling pathways to try and block autoimmunity. And on this side, often people are deficient in these factors, and so some of the interventions potentially are about trying to boost this side, you know, particularly regulatory T cells. So one of the major, I guess, light bulb moments that we've seen in the type 1 space is this concept that in type 1 diabetes, we intervene late. We intervene when the majority of beta cells are destroyed. But if you look at other autoimmune diseases such as rheumatoid arthritis, and you could also say for autoimmune thyroid disease, particularly Graves' disease, the intervention occurs much earlier, before you actually get destruction of the organ. And this is particularly the case in recent years, where a lot of these different monoclonal antibodies and other interventions are actually used to prevent destruction of the joint, of the organ. Whereas in type 1 diabetes, we're a long way behind. We still really do very little in the way of trying to intervene before we've got largely complete beta cell, or 95% beta cell destruction. And so there's been a big groundswell in the type 1 prevention space, and primary, secondary and tertiary prevention, or particularly secondary prevention, to treat insulitis as a disease and move back from that fear that we have as paediatric endocrinologists, that we don't want to give children drugs that are potentially going to have side effects, impact on their immune system, because the reality is that long-standing diabetes is associated with complications, early mortality, etc. But this requires a real frame shift in the diabetes community, particularly the diabetes community, paediatric diabetes community, and general paediatricians who often look after children with type 1 diabetes. And by nature, I think we're all relatively conservative. There's a bunch of different immunomodulators that have been used in other autoimmune diseases, and some of these have actually been used in type 1 diabetes with variable success, and I'll go through this shortly. Sadly, we were part of the Extend trial, tocilizumab, that was actually used in new onset diabetes. Didn't make any difference at all. There's certainly some evidence for rituximab and abatacept, and there's certainly a lot of space for other interventions. And hopefully one day we will actually be in the position where we will be giving these agents in stage 1 and 2 and possibly stage 3 diabetes. So this is an overall summary, but I will go more specifically through interventions at primary and secondary prevention. This is a very good review article by Colin Dayan from the UK, who's part of a big consortium that is really pushing interventions in the early stages of diabetes. I'll talk through some of these primary prevention. Sadly, most of these secondary prevention studies have not worked or have had some post hoc analysis evidence. Stage 2, the standout one is teplizumab, which I'll discuss shortly, and then tertiary prevention. There's been mixed results, and there are a number of studies that are ongoing. So Trigger, we were part of the Trigger trial. 2,000 children recruited, or more than 2,000 across Australia, Europe and North America, and sadly using a hydrolyzed formula versus a cow's milk-based formula did not make any difference whatsoever, and if anything there was a marginally better result if you had a cow's milk-based formula versus a hydrolyzed formula. So that one's been put to bed. 20 years ago, we would say to families, if you're not going to breastfeed, maybe you should be considering a hydrolyzed formula. We certainly, based on this big RCT, do not recommend that anymore. The TrialNet oral insulin showed no difference. This was a really big study, cost a truckload of money, went on for years, didn't make a difference. But then when they did a post hoc analysis, they showed that if you had dysglycemia, so loss of your first phase insulin response, then those in the oral insulin group had a positive effect. But the subsequent study has been disappointing. But you can see here there was quite a marked difference in the risk of progression in those two groups. So there is a smoking gun there somewhere potentially with regard to the role of oral insulin in those that have insulin autoantibodies, and the hazard ratio was a halving of risk, a significant p-value. So obviously the landmark study teplizumab, you can see small numbers though, 44 for teplizumab, 32 for placebo. There was a striking difference in risk of progression to diabetes in the individuals who received teplizumab versus placebo. So again, a halving of your risk and a similar p-value to the oral insulin. And the median time to diagnosis was effectively halved, but nevertheless, you can see there was ongoing beta cell decline. So teplizumab alone is not going to prevent you from developing type 1 diabetes, but it is potentially going to delay. The one thing I think that's really important about this, and you probably all know that the application has gone to the FDA for approval, and this will be a situation where we've sort of jumped from a small phase 3 trial to effectively, I think, post-marketing. This has not been replicated in any other populations. There are some studies underway in new onset, but we do have the risk that this may well not prove to be quite as an outstanding an intervention as we'd hoped, or that there will be a subgroup of individuals for whom it will be effective. Briefly, dietary interventions that are potentially going to impact on immune function, not immunotherapy per se, but certainly may well modify the immune response. We already talked about Trigger, which was a negative study. A small Finnish study did show a delay in development of autoantibodies, so it was a primary prevention study in a formula that used bovine insulin, but that has not been replicated and there hasn't been follow-up. The pre-point trial that was undertaken by the German group, Ezio Bonifacio and Annette Ziegler, a small study showed that oral insulin as a primary prevention did impact on T-cell function, and now as part of GPAD there is a follow-up pre-point study that is actually looking, rather than as a pilot, to actually delay development of autoantibodies. Late exposure to gluten, that was another German intervention, didn't make a difference. And then one of the, I guess, interesting studies that's currently underway at the moment through the GPAD platform in a number of different European countries and the UK is giving a probiotic Bifidobacterium infantis in high-risk infants. So there's some stuff out there that may well be effective. It's hard to know though whether a probiotic is really going to be effective enough to overcome that genetic risk of autoimmunity. I thought I'd just highlight, partly because my research interest is enterovirus infection, and I've spent the last 25 years looking at this using different methods. We had a systematic review in the BMJ but over a decade ago that showed the odds ratio for an enterovirus infection at diagnosis was almost 10, which is much higher than HLA, which the odds ratio is 6. And then Sonia Isaacs, my PhD student, re-looked at data and presented this at the EASD and is about to submit. We've got an odds ratio now that's significant for islet autoimmunity of 2.1, and that odds ratio for at diagnosis has jumped, it's almost doubled. So there's a very strong rationale for intervening to either prevent or treat enteroviruses. And on that note, the phase 1 study of 32 healthy adults with a combined Coxsackie VB 1-5 vaccine showed no adverse effects at all, and they're about to embark, this is in Finland, on a phase 1b/2 study in school-aged children and younger, and then the phase 3 study will be immunising infants at risk, that genetic risk, so it's primary prevention at age 3, 5 and 12 months with an endpoint of islet autoimmunity. So I'm really excited by this because I think even if we can reduce, even if we don't prevent all cases, if we can reduce the burden of type 1 diabetes, that will be fantastic. But there are challenges for primary prevention. When do you start? And ideally as soon as possible after birth. Who do you target? And obviously the high genetic risk group makes the most sense. We need to make sure we've got an effective and safe intervention. Vaccines very likely are, but with other immunotherapies, there still is a question mark. And then, do you have the endpoint of multiple positive antibodies or type 1? And as I've already shown you, it can be a 10 or 15-year trajectory if you're looking at type 1. And so most interventions are looking at the outcome of multiple antibodies, because we know then that predicts your risk of developing diabetes subsequently. And then, of course, the big issue is funding these trials that are incredibly expensive and require a lot of manpower for a relatively small population. So going back to my case, she continued to have an insulin antibody at 9, 12 and 15 months. Interestingly, she had a ZNT8 antibody at 9 months and then it became negative. And because of that, I reassured the family, well, we know with a single antibody your risk is lower than if you've got multiple antibodies, albeit that she had those other risk factors, multiple relatives. She was a DR3/4 and she got her first antibody at a young age. And then sadly at 15 months, her HbA1c was 6.1%. Which is clearly not completely normal. It's not obviously diagnostic of diabetes, but it certainly looked like the writing was on the wall. So this is some years ago now. I think she's about 6 or 7. And at this stage, really, our advice was monitor for symptoms. Nowadays, the guidance says that you should continue to do HbA1c, although we know that it's not always reliable in this stage 1 and 2 diabetes population. The ISPAD guidelines that I'll highlight in a second, led by Michael Haller, Rachel Besser and Kirsty Bell, came out saying it probably is a good idea to do an OGTT, but I don't know if any of you have ever tried to do an OGTT in a 15-month-old, but it is impossible. We are increasingly using CGM in this antibody-positive population, doing it intermittently, but it's not currently funded, so it's either got to be, we've got to get a free sample from the company or do it as part of a trial or ask the families to pay for it. And we prefer to use Dexcom because of just Dexcom G6 rather than Libre because of its reliability in this population. Obviously giving advice to families about the signs of diabetes to prevent DKA. And unfortunately, in a 15-month-old, whether it was back then or now, there are no interventions currently available once you've got multiple autoantibodies in this age group. So it's very frustrating as a clinician, this girl's part of a study, but you've got these positive antibodies, but you feel really quite helpless because there's nothing that you actually can do. So this is the ISPAD guidelines that have just come out, and the guidance recommends OGTT, but as I said, it's very difficult to do in a young child. A one-off random glucose, it's cheap, but it's not really going to be very helpful if it's normal. Obviously, if it's abnormal, then that provides guidance. As I mentioned, HbA1c is not completely reliable because it can be normal in asymptomatic individuals, but it's well established that your HbA1c rises before you actually progress to diabetes. And I already mentioned CGM, which I actually think is the way of the future. So in terms of secondary prevention, so that's this girl who's got positive autoantibodies. The trials have targeted either individuals with positive antibodies, so stage 1, or individuals with dysglycemia, so stage 2 or stage 3. And really largely most of these have been unsuccessful. There's a few that are ongoing at the moment. And the only one that's been successful in this... this column here is not the stage that's the intervention, it's the stage that is the outcome. So these are trials in stage 1 or 2, with the outcome obviously being largely whether you progress to diabetes. And you can see there's been a truckload that have been unsuccessful, the only one really being teplizumab, and a couple of ongoing studies. So just briefly mentioning the CORD trial, which is a pilot study that I've been running, and unfortunately we've been going for almost a decade because it's really hard to recruit individuals with positive autoantibodies. We've screened over 1,000 children. We tried to make this an international trial, but the regulatory side of things was enormous. So these are children who have initially a first or second degree relative, but now anyone in the general population who has stored autologous cord blood, so cord blood at birth, and then we're giving cord blood when they've got multiple antibodies. The rationale is the fact that we're giving a boost of regulatory T cells, and there's good data to support that, although whether it's enough to just give this boost of Tregs without ablating the bone marrow remains to be seen. The rationale is also that if you give something early before your beta cells are all knocked off, you're more likely to be effective, whereas the trials giving cord blood at diagnosis have largely not been effective. The other thing about cord blood is that it is incredibly safe. So we're recruiting children aged 1 to 15 years, first or second degree relative, but as I said, now we've moved to general population because we're doing population screening in Australia as part of a pilot. And if they've got 2 antibodies, we're offering the intervention. We've infused 9 individuals and less than half have progressed. So we're planning to get to 10, which we're probably going to do in the next couple of months, and then really do some immune analyses to see whether there really is a signal there. My experience has been in this trial, though, that the children that had that high-risk group, so DR3, 4 antibodies before 12 months of age, they're the ones where I just don't think you can probably do anything to prevent progression because it's such an aggressive autoimmune disease. Just, I guess, as a side issue, should overweight be targeted? This is quite an interesting study that showed that if you've got, because we know that the accelerator hypothesis indicates that if you've got tall stature, overweight, that is a risk factor for both development of autoantibodies and progression. This interesting observational study showed that by targeting BMI, or that overweight itself, so it wasn't an intervention, it was an observational study, but there was a significantly elevated hazard ratio of 1.7 in those that had a BMI above a Z-score of 1.35. So my case was diagnosed at 20 months. HbA1c was 9.5. She wasn't in DKA, which was good. And interestingly, as I said earlier, the ZNT8 was still negative, but IA2 was positive. So probably this was, as we know, what tipped her over the edge. Fortunately, celiac screen was negative. So what could we give her? So there's been more interventions that have been successful in new onset type 1 diabetes. As you can see here, rituximab, teplizumab, abatacept, ATG, golimumab, and then a number of studies that are ongoing and you know, other things that are being looked at. At the moment, baricitinib, that's the study in Australia. We're about to start a trial with abatacept and insulin, and there's some other things in the wings. So at the moment, there's nothing for which this young girl would have been, or at the time, would have been eligible for, but certainly the landscape is that there's quite a lot of stuff out there. I'll move on in the interest of time. So if we could look into the future, and this is my son, who's now a grown-up boy, taken at, on the Eiffel Tower, actually, when we're looking through the telescope. Where would we be? I think it's a very interesting concept, this whole expansion of Tregs, and it's a bit of watch this space here, as well as more targeting specific T cells. You know, I think it's an interesting area, but we've still got a long way to go. I think probably the most important issue is individualising therapy, as well as probably combination therapy. And then this is another, with again, Jeff Bluestone, who's actually now moved into the cancer world, and I think we've got a lot to learn from immune therapies in cancer. I'm nearly done. So, of course, we still need to understand how and why type 1 diabetes occurs. And even though we know enteroviruses are probably implicated, there's a whole lot of stuff out there that we still don't understand. Studies are now really exploding. We've got a big consortium in Australia. Obviously, in the US, there's lots of studies, the GPAD platform. But largely, these are limited to Caucasian populations, not low-income countries, and it's very likely that personalised and combination or adaptive trial approaches are needed. As I said earlier, even if we are able to partially present the disease, that will still have a major impact. And even if we can't prevent the disease, if we can preserve beta cell function, we know that reduces the risk of hypoglycemia and complications. And of course, all of these trials do, once we give an intervention and immunotherapy, also provide valuable mechanistic data. Okay, sorry I went a couple of minutes over.
Thank you very much, Maria. Very comprehensive history you're telling us. If you want, someone wants a question, short questions, and then go to the microphone. Microphone, please.
Thank you, Maria. Very, very nice conference. There are some children with diabetes that more than one in family, 2, 3, even 4 children with that type 1 diabetes, and they behave. There's some evidence that they behave like a more serious disease, worse A1C, and early onset of complications. Could be a different type of type 1 diabetes, this family 1?
Look, it's a good question. When you look at the NPOD data and biopsies, there is a lot of variability in what you see in terms of insulitis and destruction of beta cells. There's no doubt that if you've got the DR3/4, and particularly if you get onset at a young age, it's more aggressive. But there's some evidence that particularly your gene dose, and that's part of the type 1 risk score. If you've also got an, a PTNP11, insulin gene mutation, that does seem to be put you in a different group. I don't, we still don't understand, the insulin antibodies versus, the GAD, how that impacts on the disease. I mean, I guess it's like autoimmune thyroid disease, though. Some people have TPO antibodies, sometimes some have thyroglobulin, same with other autoimmune diseases. I guess my short answer is that there's probably different pathways, but the ultimate outcome is that you've got beta cell destruction, and in some people it's much more aggressive than others. I think, that's about the best that we know at the moment. It's very frustrating, and it's very frustrating as a clinician, when you're trying to explain to families this factor.
Thank you. Thank you. Yes. Maria, Abel. Yes, sure.
Thanks, Maria. Beautiful. Is there any evidence between coronavirus infection and risk of having type 1 diabetes in children, especially from the standpoint that we have a vaccination? Is there any evidence that is solid?
So there's been some interesting data, and in fact, I've got a student at the moment who's just about to submit a systematic review on this. So if you look at the basic studies, there are coronavirus receptors on the beta cells. So it's plausible that, if you were to get a coronavirus that went through your gut and up the pancreatic duct, it could set off inflammation. I think it's too early to tell now because, you've got to do these cohort studies, and in the India study we are looking at coronavirus as a trigger for autoimmunity as well as progression. So it's plausible. Most of the epidemiological studies, though, that are at onset really aren't convincing that coronavirus has an etiological role. There's absolutely no doubt that viruses will tip children over the edge. They've got islet autoimmunity. I mean, that's really what, a lot of our, that's why the odds ratio for enterovirus is 16. Some of it's possibly etiological, but some of it's just that enteroviruses are ubiquitous, and, if you've got sick beta cells and you get an enterovirus, it'll knock you over to progression. I think we need more time because we've only had nearly 3 years of coronavirus. I think we need more time to really answer that question properly. Interestingly, though, we've just through our ADN registry, had a paper in Lancet Diabetes and Endocrinology that looking at different registries across the globe, and coronavirus does seem to be implicated in a greater risk of diabetic ketoacidosis. But that could well just be behavioural, because during lockdown, people were much less likely to present, and so it's a bit of a mixture of, circumstantial evidence versus, the etiological evidence. So the jury's out.
Thank you. Maria, I'll be the clinician if I have a patient that has type 1 diabetes and they have other 1 or 2 brothers or sisters, so would you recommend, it's a very simple question, but it's a very important one, I guess, from the clinician perspective. Would you recommend to measure antibodies for the sister and brothers?
Yeah, look, it's a very good question. I treat each family on an individual basis. Some families don't want to know, and some families request it. The problem is that we don't have an intervention at the moment, although that may well change, particularly if teplizumab does get approved by the FDA. Whether that will be rolled out in other countries, I still think it's probably a few years away. But the rationale for a lot of these population screening programs, so I know you're talking about first-degree relatives, but the population screening programs is prevention of DKA. And there's very good evidence, that from both screening first-degree relatives and I think John Wentworth, who did a study for people who were screened as part of TrialNet, categorically showed there was a low risk of DKA. And the corollary of that is that there's very good evidence now that if you have DKA at diagnosis, you've got less beta cell preservation, cognitive and brain MRI changes, increased risk of complications, and higher HbA1c down the track. And again, we just had a paper in Diabetes Care showing that from the ADN registry. So I think the answer is there is merit for prevention of DKA, and then obviously long-term benefits of prevention of DKA. There's quite good evidence that psychological function is not generally affected in these families. Obviously, initially there's anxiety, but then once you go through monitoring, families are often prepared, and that's been my clinical experience. And, you know, I've had part of India, I've had a handful of children who have been diagnosed based on their CGM. So they're known antibody positive. We see them every 3 to 6 months. We do CGM every 3 to 6 months. And, you know, the CGM trace showed an average glucose of 12. Child had no symptoms. You know, I rang the mother, said, look, you know, you need to think about this over the weekend and we'll organise to you know, start treatment, get your monitoring. And for that family, that was a much more positive experience than winding up in intensive care with ketoacidosis. So I actually do, I've come around. I used to be a bit more sitting on the fence, but I actually do think there is merit in terms of being able to prepare families. But also, you know, if you're autoantibody negative, and particularly if you're autoantibody negative by age 10, your risk of developing type 1 is extremely low when you look at the life table analysis. So that provides a lot of reassurance to families.
Okay, in a scenario that you don't have the access to antibodies, and the family wants to perform, for example, hemoglobin A1C at interval, would you recommend that?
I mean, you've got to remember that 95% of first-degree relatives aren't going to get type 1 diabetes. And so I think from a health economic point of view, doing serial monitoring of HbA1c in first-degree relatives or the general population is a waste of money, to be honest. I think it's much more appropriate to be doing autoantibodies. And in Australia, we're evaluating 2 different strategies. One is genetic screen, because you'll pick up about 10% of people who are at risk. This is general population, but also in first-degree relatives. If they've got the high-risk HLA, then they should be monitored. If they're not high-risk HLA, then they probably shouldn't have autoantibody screening. But the answer is no, I wouldn't be doing HbA1c or glucose monitoring in family members. Sorry, we're over time.
No, we have one more minute. So you mentioned that the risk for transmitting diabetes is higher for father than mother, and we know that. And the other side, you showed an odds ratio that 1.3 to female to male ratio.
Yeah, it is a bit confusing. I think it's because, so this was a young cohort, and when you look at the epidemiology of type 1, there's a slight female bias up until puberty, and then post-puberty, particularly in adults, there's quite a strong male bias. So I suspect it's probably hormonal. I mean, there's lots of endocrinologists in the audience. It probably is related to hormones, and other factors. Nobody really understands that genetic dichotomy, but
because the risk is higher for the father transmitting the disease, is there any imprint? Is there imprinted genes around in type 1 diabetes?
It's a very good question. I'm not aware of any data on that. It's actually thought that if the mother has type 1 and she will largely have autoantibodies, that those autoantibodies cross the placenta and therefore provide some immune protection to the offspring. So so rather than being an epigenetic or genetic factor, it's possibly just, immunomodulation from maternal autoantibodies.
Thank you, Maria. Thank you. And thank you, all of you, for your assistance. And thank you for your excellent conference and for your questions and your answers. Thank you very much.